Hey, how's everybody? So we are here tonight to talk about erectile dysfunction. Hopefully everybody can see me and my slides okay. And we're starting off with a nice pun, hard facts on erectile dysfunction. I am your host. I'm Dr. Sharma. I'm coming to you from Chesapeake Urology, where I'm one of the men's health specialists and urologists operating out of the Germantown office in Maryland. I have a number of specialties, mainly erectile dysfunction, Peyronie's disease, low testosterone, issues with ejaculation, and a number of other men's health topics. You can see my education here. I'm a Maryland guy, born and raised, went to College Park for undergrad, and was up at Dartmouth for medical school before coming to Charlottesville, where I was at the University of Virginia for 6 years in training and in fellowship in men's health. So we're going to jump right into our agenda for today. We're going to be talking about erectile dysfunction, or ED, and we're going to start off with what that is, what some of the causes of erectile dysfunction are, and how ED is really a health indicator of what's going on in your body, specifically what's going on with your heart and your blood vessels. We're going to spend a good amount of time talking about treatment options because ED is one of the oldest problems known to men, and guys have been trying to find creative solutions to fix this problem for years and years. So we'll look into all the different options, from pills to injections, vacuum pumps and implants. And then I'll show you a couple of videos. We're going to see a video about how exactly an implant works, and we're going to show you a video about a patient experience as well. And I think the best part of the night is when I have an opportunity to actually answer some of your questions. So you'll notice that there's a little chat bar. Feel free, as I'm going along and talking, to throw your questions in there. It's not going to interrupt me. It's actually helpful to put them in there while they come to your mind. And we'll go through the end and hit on as many of those as we can. So let's go ahead and jump right in with what is ED. ED is the consistent inability to sustain an erection sufficient for sexual intercourse. So what does that mean? That can mean a lot of different things. That can mean either a complete inability to get an erection. That could mean not getting an erection when you want an erection. That could mean getting an erection, but it's not hard enough to do what you want with it. Or that could mean that you're able to get an erection and it's hard enough, but it's not lasting long enough for you to have a satisfying sexual experience with it. So ED is very, very common, but that doesn't mean that it's normal. So a lot of guys experience ED. It's something around 30 million in the US alone, which ends up being something like 1 in 4. So most people who have it know at least one other person and have talked about it before. But again, just because it's common doesn't mean that you should write it off as, oh, this is just a normal part of aging, or this happens to so many guys, it must be fine. I don't really have to worry about it. It's really the opposite. It's something that you should definitely pay attention to. We're going to talk a little bit about causes of ED, but the reason to pay attention to it is because if it's happening to your penis, chances are there's something else going on in your body that may be an underlying cause. And we're going to touch on some of those here. Now, the most common causes of ED are the same things that lead to severe heart disease. So you'll see a list down here at the bottom of this slide. Injuries to the brain or spinal cord, certainly anything that disrupts the nerve flow from your brain down your spinal cord through the nerves that go to the penis can interrupt a normal erection. Those are not as common, but those are a huge contributor to men who have ED. Now, a disease, that's really where most men are affected from an erection standpoint. Diabetes is common, high blood pressure is common, heart disease is common, and those are all highly associated with erectile dysfunction. Surgeries can do it. In our world, one of the most common surgeries is the removal of the prostate for prostate cancer. It's a highly effective treatment, and it's a great option for men who have prostate cancer, but unfortunately, it really leaves you with erections that are nowhere near what they were like before the surgery. And finally, substances. And really the most common substance is tobacco, which is smoking, and alcohol use. Now, other street drugs can certainly play an impact here. Everybody wants to know, what about marijuana? Well, there's probably a nuanced answer to that, but to keep it simple, marijuana can really drop your testosterone levels, and testosterone plays a very, very important role in maintaining good, strong erections. So let's talk a little bit about ED as a marker for cardiovascular disease, because this is really important for guys to understand. I see a lot of men with erectile dysfunction, and everybody wants to know, what's wrong with my penis and how do I get it better? Well, before we get to that, it's really important to understand that what is happening in your penis is usually a marker of what's going on with your general health. So the penis is a vascular organ. That means that it has a lot of blood flow to it, just like your heart. So when you have chronic health conditions like high blood pressure, cholesterol issues, diabetes, obesity, smoking, all of those things affect the health and the quality of the blood vessels in your body. Those are the same things that put men at risk for dying from heart attacks and strokes. And it's the same thing that puts men at risk for erectile dysfunction. And the arteries that feed the penis, that send blood to the penis, are really small. So they're one of the earliest blood vessels to be affected. It could be the first marker of men who are going to develop heart disease later in life. Here are a few other risk factors. Aging is an independent risk factor, and we'll talk in more detail about each of these four in the coming slides. Chronic diseases, you're going to hear me say it over and over again in this talk. High blood pressure, diabetes, cholesterol issues. Here on the slide, you can see depression and heart disease on there also. Now, this is a little bit of a catch-22, because say somebody has high blood pressure and we're trying to get it under control, and oftentimes that can help with improving erectile function, but some of the medicines used to treat high blood pressure, like the thiazide diuretics, which is a water pill, or beta blockers, can actually play an impact in decreasing some men's erections. That's not to say that those medicines are bad. Those are important medicines, especially for men at risk for heart disease. But sometimes there are alternatives that we can recommend in conjunction with a primary doctor or cardiologist that can be a little bit easier on your penis. And then lifestyle is huge. So there's a lot that goes into a normal, strong erection, and that really starts up here. And there's nothing like stress, alcohol, and smoking to really set your erections back. So let's talk a little bit more about aging, because I said earlier in the talk that just because you're getting older doesn't mean your erections are going to go away. But there is a big association. So you're at higher risk as you get older. And that could be because of a number of things. Number one is it's just more common to have some of these chronic health conditions like cholesterol issues, blood pressure issues, diabetes issues. But there are a lot of other changes that happen with age. There are changes that happen in men, and there are changes that happen in our partners. And that can play an impact with your relationship, with your level of arousal, with your level of stress. And those are all implicated as we age. This is more details about diabetes and high blood pressure. And really the take-home messages here is, if you're a diabetic, how high your blood sugar is, how high your A1C is, how frequently you're having big spikes in your blood sugar, those all play an impact in how bad your erections might be. So diabetes affects a lot of things in the body, and some men have issues with their nerves with diabetes. So if you have neuropathic pain, which could be numbness or tingling in the fingers or toes, then that's certainly already affecting your erections also. Or if you have diabetes and it's starting to affect other organs in your body, like your eyes or your kidneys, it's probably already affecting the penis as well. And this part about high blood pressure is just to show high blood pressure is very common, and it's called the silent killer for a reason, because really, unless you check it, you typically don't know that you have it. And this just shows information from a quick study that had 100 or so people with high blood pressure, everywhere from 35 to 75. You can see exactly how common erectile dysfunction was in those men. Almost 70% had some form of ED, and almost half of those were severe. This slide shows you how chronic diseases affect erections kind of on a scale. So if you have diabetes, you are 4 times more likely to have issues with erections than if you were not a diabetic. And this just runs down the list here. Prostate disease is important. Peripheral vascular disease, meaning impaired blood flow, usually to the legs, is a big risk factor. Heart problems, hyperlipidemia is issues with high cholesterol, and high blood pressure or hypertension. Let's talk a little bit more about prostate cancer, because there can be a little bit of confusion here. When men have prostate cancer, they typically have little to no symptoms. So it's not like if you have prostate cancer, that's the reason why your erections are poor. It mostly has to do with the treatment for prostate cancer. And if we have some survivors that are tuned in and listening to this talk, you know exactly what I'm talking about. Because whether it is radiation or surgery to the prostate, these both have profound impacts on the quality of your erections. With surgery, it's boom, it happens all at once, because there's literally no way to take out the prostate and all of the cancer that may be in the prostate without affecting the nerves that travel from your spinal cord to your penis. They just pass through that area. And even with really excellent and advanced nerve-sparing techniques, with the best robotic and contemporary trained surgeons, it's never quite the same after surgery as it was before. With radiation, it's a little bit different. It still impairs the erections, but it might not manifest until later in treatment. A lot of men who are on radiation actually get placed on hormone therapy at the same time, and that drops the testosterone level and can affect the erections in the early stages of treatment. Later on, when men are off of the hormone therapy, and even if their testosterone is getting back to normal, unfortunately, the longer you wait after radiation, the more damage that has occurred to the nerves and the small blood vessels that go to the penis. So after radiation, it may take a little bit longer, but men often have issues with erections after that as well. I cannot emphasize how important smoking cessation is to improving erectile function. One of the big take-home messages from this slide here is that smokers are at 2 times greater risk of having issues with their erections. So if you are a smoker, you have almost certainly heard it from other doctors before, you have to quit smoking. You probably haven't heard from a doctor that you have to quit smoking if you want your erections back. So the other important thing to note here from this slide is that when you quit, your erections can get better. And we see that because in former smokers, the rates of ED are much lower than in current smokers. And then the last thing that I'm just going to touch on again is medications. And it looks like we already have a few questions coming in about this, and we're going to address that in more detail at the end of the session. With the thiazide diuretics, hydrochloric thiazide being the most common, and beta blockers like metoprolol and propranolol can play an impact in erectile function as well. So let's talk a little bit about how an erection occurs. And I'm going to go through this twice because I want to show you some pictures also, because sometimes that can be a little bit more instructive. So a man can't get an erection just because he wants one, okay? There has to be some element of arousal. And to keep it simple, that can be fantasy, something that you are looking at, something that's going on in your head, or that can be friction or physical stimulation in the genital area. Once there is some form of arousal in place, there are signals that go from your central nervous system, whether it be your brain or your spinal cord. Those signals get transmitted to the penis. Those signals are telling the arteries and the blood vessels in the penis to change and accommodate more blood flow. There's a rapid filling of blood in the two big spongy chambers on the top of the penis. And as those chambers fill with blood, the penis gets longer, it gets fatter, and it gets harder. And that's what leads to an erection. Let's take a closer look at all of that. This is two cross sections. One is of a man facing sideways. One is of a penis kind of cut in half. So here is the flaccid state. You can see in the cross section of the penis on the right side of the screen that there are those three chambers. There's two chambers at the top, and every man has felt this before. When the penis gets hard, the top of the penis is nice and hard, the bottom of the penis is pretty soft, and that is where the urethra or the tube that you pee through is. So at this point, the penis is flaccid. There's some form of arousal, and again, it's fiction or fantasy, and that's when the blood starts rushing into the penis. You can see here that as there's engorgement, there's elongation, there's thickening of the penis, and as that continues, when the penis is fully erect, those two chambers at the top are completely filled with blood, and to a certain degree, they're trapped there. They collapse the veins that hug these chambers, and that allows you to keep and maintain an erection. So a lot of men who are able to get a partial or a full erection, but it doesn't last that long, it's not actually an issue of blood getting to the penis. It's an issue that the blood is not staying in the penis. And that can be detected on an ultrasound that we do in the office. So let's go ahead and jump into treatment options, because this is really where I think everybody is going to get the most benefit is from learning about these. So the first thing is the pills. Now, the pills have not been around for forever, but as soon as they hit the market, they quickly became one of the most common treatments for erectile dysfunction. And it's usually everybody's first stop when they go and see a doctor with issues for erections. And there are a lot of different pills. They're all part of the same family. They all basically do the same thing. So everyone has heard of Viagra, there's Cialis, there's Levitra, there's Stendra, there are all these brands, but again, these are all part of the same family. And some of these are actually generic. So sildenafil is the generic for Viagra. Tadalafil is the generic for Cialis. The way these pills work is that when you take the pill, it helps your body and it helps your penis achieve the blood flow that is necessary to get a normal erection. But you still need to have all of the other pathways intact. So if you have severe nerve damage, whether it be from something like a prostatectomy or something like diabetic nerve damage, these pills may not be effective. And that's really one of the downsides, is that these pills don't work in up to a third of men who try them. They're not automatic, so if there's stress, if there are other components in the bedroom that may be hindering your ability to get normal erections, these are not going to make those go away, okay? And then there's the other element of spontaneity. You have to time these medications right. Most guys come to me and they're like, doc, the pills didn't work. Well, the pills may not be working if you're taking them right after dinner, waiting 20, 30 minutes, and then you're trying and it's not really doing anything for you. Well, that's because it takes a little while for these medicines to get from your mouth to your stomach, to your gut, to your bloodstream, to your penis. And usually I tell guys, again, for most of these medications, wait at least an hour. And for some of these medicines, if you're taking it after food or with food, you might as well be flushing half those pills down the toilet, because they just don't work that way. Side effects for these are pretty mild, but if you have them, they're really irritating and they don't exactly put you in the mood for sex. So potential side effects are headache, super common, flushing, feeling like red or hot in the chest or face, some upset stomach. People can have like nasal symptoms like congestion, and especially with certain medications like the sildenafil, you can have mild or temporary vision changes. So when men have tried a couple of pills and they are not working, that's usually when we start opening up the arena to all of the other different treatment options we have. And one of the most common, and this is actually one of the oldest therapies, is injection therapy. So the advantage to the injection therapy is this is an erection in a vial. So this is completely independent of arousal. You can be watching baseball, and if you inject yourself, you're gonna get an erection, okay? These are quick in onset, so after you give yourself the injection, between 5, 10, 20 minutes later, you're gonna see a response. But the downsides are pretty obvious, and the first one is it involves putting a needle into your penis, and not everybody is okay with that. There's also the element of spontaneity. So yes, you don't have to wait the 30, 60, 90 minutes for the medicine to work, but it can be a little bit cumbersome to have this setup. Oftentimes these medications need to be refrigerated. You have to draw up the correct amount of the medication into a syringe. And if you're not in a pandemic and you're traveling around, then that can be hard when you're traveling with needles or when you're traveling with a medication that needs to be refrigerated. There are other things that you're going to see here on the slide. Obviously, it's a really small needle, so bleeding at the injection site is not very common unless you're on blood thinners. You can have pain at the injection site, and that might not be from the needle itself, because again, it's a very small needle, but it can be a dull ache from some of the medicines that we use. And that's just a normal effect of the medicine. It's not an allergy or anything like that. It can be a little bit tricky. So usually we always do the first injections in the office. There's a urologist that will be there and will teach you exactly how to do this in a safe way. But even if you do it in the safest way possible, this can cause things like bruising. Or if you've seen any of the commercials for the pills, you'll hear, oh, please see a doctor if you have an erection lasting longer than 4 hours. Well, for guys with ED, that might sound great, but if you have an erection that's lasting longer than 4 hours, it's usually associated with pain. And that means that the blood in your penis is trapped and it's suffocating. And every minute or hour that you wait after that, you're actually losing tissue in the penis. So that doesn't really happen with the pills, but that can happen with the injections. And when that happens, you can run into this thing called cavernosal fibrosis. So either from the injections itself or from erections that are lasting a little bit longer than they're intended to, you can get permanent scar tissue within those big spongy chambers that can limit the penis's ability to fill normally with blood. Peyronie's disease is something that some men are familiar with. This is a condition of the penis where abnormal scar tissue develops from some type of microtrauma. Usually that's sexual activity, but if you're a man who is predisposed to Peyronie's disease because of a family history, then if you start injection therapy, that actually might be the small amount of trauma that sets off the cascade of abnormal scar tissue and can lead to permanent curvature changes. And then the other thing is, again, most people with the injections, they do fine. They don't have major issues with bleeding or with pain. But for whatever reason, when guys start on injection therapy, by the end of a year or two, 80% of them have stopped using the injections. And I don't think we completely understand why, but it's some combination of, hey, it might stop working for you. You might realize that this is not as spontaneous or allowing for the type of sexual experience that you were hoping for or that you were used to. So for whatever reason, guys don't stick with these injection therapies for very long. The vacuum erection device is something that you may be familiar with, especially if you've watched an Austin Powers movie. So this is a chamber that is placed over the penis externally, and it's a negative pressure device. It's a pump of sorts. You place the chamber over the penis, you turn on or you pump the device, it draws air, pressure, blood flow into the penis, and that allows you to have an erection. These don't work alone, so this helps draw blood flow into the penis. But in order for it to stay there, this has to be used in conjunction with a veno-occlusive ring or a cock ring. And that's where this gets really finicky. So the advantage of this therapy, it's on demand. So, you can use it whenever you want. There's no interference with any medications or anything like that. To be a little bit careful if you're on a lot of blood thinners because of bruising concerns. It's totally non-invasive, so there's no needles involved with this. There's no surgery involved with this. It is safe. It does work. You have to get the right ring to get it to work, but it does work. No drugs. It's a one-time fee, so you buy it and then you have it. You can use it as much as you want. And then there are some other therapeutic benefits to this. So some men who are signing up for treatment for prostate cancer can use a device like this for what's called a penile rehabilitation program to help decrease length loss and help preserve some erectile function. But again, there's a little bit of training and getting used to a device like this. What I tell guys is that the actual pump part is really easy and straightforward. It's that ring. Getting the right fitting for the ring can be really tough. And in order to keep the blood flow trapped in the penis, you have to have a good snug fit. And it's a little bit of a, walking the tightrope, because you don't want it so tight that you're suffocating the penis and like hurting the skin around it, but you also need it tight enough where it's doing its job. And when it does get that tight, that can lead to discomfort, that can lead to issues with ejaculation. And again, it's just part of what makes the learning curve for this a little bit tricky. There are insertable drugs, so these are called urethral suppositories. I'm really not going to spend a lot of time on these. They exist. They're the same family of medicines that we use for the injection therapy. It's just placed inside the pee hole instead. They don't really work that well. They do cause some pain and burning. And once you've placed them, you can actually transfer that medication to your partner during intercourse. So this exists. It's not something that we typically highly recommend because there are better things out there. So let's get into the implant a little bit. A lot of guys who have erectile dysfunction, when you go on the internet, this is one of the first things you see and one of the first things you learn about. So implants are very common. There are two types. There is the malleable type, which is basically fancy metal rods, and then there's an inflatable type. So I'm going to show you a little bit about the malleable first. This is the simplest, the quickest to put in, the lowest complication rate, and the easiest to get started and start using after surgery. So the advantage for something like this is it is very, very easy to use. If you have ever seen a gooseneck lamp, one of those lamps that have an arm that you can bend and they hold in place, these rods are designed exactly like those. So you can see in this diagram, the blue cylinders are the metal rods. They're inside the penis. So this is a surgery. You can't really see it from the outside. The penis looks completely normal. But what these rods do is they allow you to bend the penis straight, like you see in the bottom part of the slide. And that is hard enough to use for intercourse. And it's literally that simple. There's zero learning curve. There are no extra parts. It's just two cylinders that go into the two chambers that are supposed to fill with blood. And they don't fill with blood anymore when you replace them with metal rods. But that means you don't really need to rely on arousal. And you don't need to rely on needles or medicines or anything like that. You bend it into place. You use it for as long as you want. You can climax. You can orgasm. It's not going to go away because it doesn't work that way. So after you have climaxed, you can keep going if you want. And then when you're done, you fold it away. Okay. Some of the possible disadvantages, these are metal rods. So if a partner is feeling your penis, if you're feeling your penis, you're gonna feel that there's something in there, okay? If you were to just look at it, you may not notice, but if you were to feel it, you would definitely know that there's something there. And then the other thing is that they may show through clothing. Now, I think a lot of people say that, but most guys I see for penile implants are not shaped like underwear models, if you know what I mean. And unless you are part of a nudist colony or spend a lot of time in Speedos, this is not really something that people are going to see through your clothing. Okay, this is something that is reasonably concealable, but not really as concealable as the inflatable. And that's what makes the inflatable device really so popular. So this is the 3-piece or the multi-component inflatable penile prosthesis. There are a number of advantages to this that overlap with the malleable device. So this is an erection on demand, whenever you want it, for as long as you want it, and it is hard enough to use for penetration. This oftentimes is actually harder than a regular erection, just like the malleable devices, but this is 2 chambers that are not metal rods, but they are empty cylinders that can fill with fluid. That fluid is stored in a little reservoir or a balloon that's tucked away and hidden into the belly cavity. And fluid can be shifted from that reservoir into the cylinders with a pump that's hidden inside the scrotum, either in front of or behind the testicles. So when you want to have an erection, you grasp the pump in the scrotum, you use the other hand to pump it up. And we're actually going to show you a video that is going to make this very clear. So again, the advantage to this, a lot of overlaps with the malleable device, but it's easy to use. You can tuck it away with just a 1 touch on the pump. This is totally concealed inside the body, so there are no external parts on this picture that you see. It's basically like an X-ray view of the body, so you can see all the internal parts. But if someone were to just look at your body with an inflatable device in place, they wouldn't see anything different. And again, this is a little bit more natural in the flaccid state. So compared to the malleable implant, when you're flaccid and you're not using it for sex, you might see a little bit of a bump. This is a far better device if you're concerned with how it looks when it's flaccid. Okay. When it's erect, it fills with fluid that doesn't really allow for the penis to get much longer. This is a device that is completely custom fitted to you. So during the surgery, we fit the biggest cylinders that your body will accommodate safely. And those as they fill with fluid, they do get thicker. And that's what allows you to have the rigidity necessary for intercourse. Let me go ahead and show you guys a video here. And as I play this, I'm going to talk you through exactly what's happening. So this is the Titan inflatable penile prosthesis, which is an awesome name. Everybody wants to have a Titan in their body. This is the male genital anatomy, and this is the implant already in the penis. The reservoir is where the fluid is held inside the belly cavity. You see the 2 cylinders, and you see the pump hidden away in the scrotum next to the testicles. You squeeze the pump, and that transfers the fluid from the reservoir, which is in the belly cavity, to the 2 cylinders that are implanted inside the penis. That's it. Reach down, pump it up, use to your heart's content. This is the deflating process. 1 touch, you want it to go faster, you just fold it away. And that's what he's doing there with his other hand. That's it. Simple. So this is a surgery and this is an implant. So this is a foreign body, and there are important things to realize with that. You know, anytime you do surgery, you have to talk about bleeding, you have to talk about infection, you have to talk about hurting things in the neighborhood. So For here, the most important thing to understand is that infections with implants are a very big deal. There's no take some antibiotics or keep an eye on it, or drain a little bit of the fluid and you'll be fine. If you get a real infection with a penile implant, you have to take the whole thing out. And most people would recommend a period of recovery after that before replacing it with a fresh implant. There are other things that can go wrong with this, especially with the inflatable device, because it's a mechanical device, right? There's tubing, there's a pump, there's a chamber of fluid. So just like you take your car to the shop and get regular maintenance on it, you're not getting regular maintenance on the inflatable device, but you're going to have some mechanical failures. I mean, if you're lucky enough to have a device like this for 20 years, chances are you may need to go in and get a tune-up, whether that means replacing some components or swapping it out for a fresh one. That's something that is kind of expected over the life of the device, typically only after 5, 10, 15 years. Most guys never need to have this done, depending on what kind of device they have and how long they have it. You can have issues with erosion, which means wearing away of the tissue next to the implant. That typically happens more commonly in people who have the malleable device and don't have normal sensation there, either because of diabetes or because of things like spinal cord injuries. You can have migration, which just means moving of parts. So that reservoir is nicely tucked away inside the belly, but it can move and it can herniate on rare occasion. Chronic pain is not typical pain at the site of one of the components. Like if you're talking about pain around the pump itself, that can be a bad sign of infection, but just pain with it being in is really not that common. After the initial recovery period, there's not any pain associated with this. But device malfunction, I mean, that was what I talked about before. It's like, buying a car and needing to have some work done at some point in time. So before we go into questions, and I see a number of great questions in the chat area here, we typically have a patient who shares their experience, and instead of doing that today because of the format that we have, what I'm going to do is I'm going to show you a video that we have put together that really shows the patient experience nicely. So let's take a look at that now.
Hi, my name is Stan Rydelic, and I'm 61 years old, and I live in South Carolina.
I'm Teresa Rydelic. I'm 60 years old, and I met this gentleman when I was 15 years old, and we've been together ever since.
I've been married to my wife, Teresa, we've been debating this, 39 years. 39 years. 39 years of bliss. About three and a half years ago, I ended up getting ill. I thought I had the flu. It turned out that I had complete liver failure, and so unfortunately, or fortunately, I had to have a liver transplant. As part of the procedure to nourish my liver, I found out what they did is they rerouted some of my blood flow, and so I ended up with a condition called arterial insufficiency, which basically means that the lower part of my body had insufficient blood flow. After I had my liver transplant and I was feeling well again, and then I found out that things were not happening romantically. It was kind of a surprise. So what I did was I asked my general practitioner, and so he immediately says, well, you know what? All you need is some Viagra. So what he did was he gave me a prescription for Viagra. I went home. I remember that evening, I was thinking, oh, how wonderful, Viagra. Of course, it's going to be a great evening. So what I did is I put some music on, poured some wine for my wife, lit some candles, and guess what? Nothing happened. So I went back, and and every time we're going in, it's just like it's 2 weeks or so between appointments, and it's still like nothing's happening, and you start to really get very discouraged. So the doctor gave me a choice. He says we could use vacuum erection devices, he says, or we can also use an injection. So I said, well, let's try the vacuum thing first. That was horrifying. Well, first of all, in my opinion, it was horrifying. It didn't really work. So that was like a one-time shot. And then we tried it was Trimix that I tried. And so I thought that was going to be great. Went home, and again, since there was a tiny bit of success, I thought this was going to be a great evening. So you try to get all romantic, and then you say, oh, excuse me, honey, I have to go into the bathroom and inject my penis with Trimix. I did everything that I could, and quite honestly, I had never even heard of a penile implant. And so when this doctor I went to, he was a young gun, kind of like, cutting edge, and he says, I think the only thing that we could do, he says, to really guarantee that you can get an erection is a penile implant. So Teresa was a part of the process. She came to the doctor's office with me, and what we did is we had the discussion about it in penile implant, and she said, look, if it means that much to you, she goes, I want you back how you were. I want you happy. A couple things came up. The first one that I worried about was the procedure, a painful procedure. And quite honestly, I was told, and after experiencing it, it's an outpatient procedure. It takes less than an hour, in many cases a half an hour or less. Another thing that concerned me also, and this one's going to sound really, really very strange, but I really worried that I would have the desire to have sex.
Well, it's kind of ironic because that's exactly how I felt. I felt like, well, he's going to get this implant. We hadn't had sex in so long. Maybe that chapter's over. And I think that a lot of women worry that they're not going to be ready for this new adventure like they were. And it actually has been a renewal of our relationship in one area. And so I'm glad. I'm just glad it's freeing. It's taken on where we can be spontaneous, just so different than years before.
There was a romance.
Yeah.
There was a spark that was put back that we didn't know went out. The thing that's really, I think, been wonderful with an implant, with the implant, which I honestly, I don't consider I have an implant anymore. It's just, it's a part of me.
Right.
There's no, well, first of all, from the standpoint, if you look at me, if you saw me in the shower or whatever, you cannot tell that I've had an implant at all. And then also from the other standpoint is you have complete spontaneity. There is never anything where you have to say, okay, you know what, I'm going to take a pill and wait a half an hour for it to happen. If you're in the mood, you're in the mood.
Right.
And it turns back the clock. I mean, I honestly feel like we're in our 20s or 30s.
Since the implant, there's a confidence there that is actually very sexy. And that confidence is something that I think the implant did for us. And I don't worry that it was me, that maybe I wasn't something that he was needing. No, we're perfect for one another, and now we have back our love life. If I could give some advice to someone dealing with this, a couple dealing with this, I would say talk to one another, be honest and open and loving, because the answer may be no. The answer may be, no, I don't want to do this, and it may be, I've been thinking about this. So I think communication is the key.
If I could give a piece of advice to anyone suffering from erectile dysfunction, it is the fact that you have one life and you have the choice to choose how you live your life and at what level of quality you live your life. So if you're suffering with something like erectile dysfunction, that's fine. You can live with it, but you don't have to. It's something that is so easily fixed, and you could have the quality back in your life that makes you a whole person again.
That was great. So one of the things that I love about that video is not just the fact that, they touch on so many of the treatments that we discussed, that, his experience with the vacuum device, his experience with the trimix or the injections, with the pills. It's really the relationship component here that's most profound to me, because this couple did such an excellent job of sharing their experience and showing us how dynamic this is. Okay, it's relatively easy for us as urologists and men's health specialists to give somebody their erections back. Okay, this is a really satisfying part of what we do. Most of us have done extra training to get to this point where really all we want to be doing is helping restore people's function in an element of quality of life that is so important and so personal, and really honestly not something that most people talk to their doctors about. But what this couple is able to do is able to really show how dynamic this is. This is not just about how hard we can get your penis, how easier the spontaneity aspect of it or anything like that, but this is about confidence. This is about, repairing or restoring relationships, rebuilding bonds that you have with your partners, or doing something for yourself that is going to help really bring back the function that you once had. And I think that the couple here does a really excellent job talking about that. I want to jump right in to some of these questions, and I see a lot of questions and excitement just during the course of that video about the implant. I want to start from the top and hit on some of the things that can cause the erectile dysfunction. We have one question here. Can you speak to the effects of radiation and brachytherapy on ED? I haven't had my prostate removed, but I did have radiation and brachytherapy, and I'm having ED. So we do know a little bit about the combination of external beam radiation and brachytherapy. That is an emerging therapy for higher risk prostate cancers, and it's excellent from a cancer control standpoint. But unfortunately, that does mean that the nerves and the arteries to the penis are to a certain degree getting a double dose, and that compounds with time. So if that wasn't apparent initially, it may become more apparent as the years go on. Now we have more questions here about high blood pressure and some high blood pressure medications. Now, without going into specifics, we have a couple of examples here. I've begun taking a beta blocker to treat high blood pressure and now have ED. Will switching to an ACE inhibitor or an angiotensin receptor blocker improve my erections? That's a great question. And to a certain degree, you don't know until you try. One of the great things is that if you were placed on a beta blocker and if it was just for high blood pressure, then you do have alternatives. And switching to something like an ACE inhibitor, one of the common ones being lisinopril, or an angiotensin receptor blocker, that may help. But that's something that should always be done in conjunction with your prescribing doctor. And that could be your primary or your cardiologist. So how common is it for oral medications to stop working over time? Well, it's super common, because erectile dysfunction is a progressive process. So it's not just something that all of a sudden happens to you one day and then it's never the same. I guess unless you had prostate surgery or big trauma to the spinal cord, it's usually something that's slow and progressive over time. So if the pills were working for you initially, they may not work for you as time goes on. Do most men find the injections to be painful? You'd be surprised. I mean, that's like one of the most common questions that I get, because I'm putting a needle into your penis. Again, the injections themselves, they're really not that painful. And the needle is so small that a lot of guys don't even feel the injection itself. Some of the medications, again, they can cause an ache, and you can switch the medications around because there are a couple of different mixtures that we use so we can get the right dose and combination for you. But yes, to a certain degree, some of those medicines can cause pain. How long does it take for sildenafil to reach peak efficiency or efficacy? So it takes longer than most people think. Again, the ideal benefit from sildenafil, which again is the generic for Viagra, is if you wait 1 hour to 90 minutes after you've taken the drug. Okay. Is recovery from the penile implant procedure painful? And I think that was addressed in the video. It's really not as bad as you think. Every surgery has a recovery process. Every man recovers a little bit differently. Most men, I'm actually reminding, hey, we just did a pretty significant surgery on you. Hold back a little bit. You are not ready to use this thing yet. Everybody has a different timeline for when they recommend that men start cycling their device or men are allowed to use their malleable device. But usually the actual period of time after surgery that it's painful, week, couple weeks, it's really not that bad. And we do a lot of things to help decrease that and make it a better experience, whether it be using, sandbags for pressure, ice to minimize bruising, scheduled over-the-counter medicines to really minimize the amount of opioids that we're using to prevent these issues like constipation, addiction. Really, you can have a penile implant placed, take nothing but over-the-counter medicines, use a good cold frozen bag of peas, and do just fine after about a week or so, 2 weeks. Let's see. There's a question here about using stem cells in the penis. So that is a newer therapy that's still under research or investigation. So we don't know enough about stem cells to really, that's not ready for mainstream yet. There are trials available at some centers for that. So that's an excellent question. So this is a good one. I'm curious to know more about testosterone level drop-offs in older men, and also how that may play an impact in erectile function. So this is actually part of our national guidelines on erectile dysfunction from the American Urological Association. So if your doctor hasn't talked to you about your testosterone level yet, please ask them the question. Because if your testosterone levels are low, then optimizing those or bringing back and restoring those levels to a normal range can really help augment your treatment, kind of regardless of what it is. If you're using pills, if you're using injections, if we get your testosterone level back to a normal level, it will help. And maybe if you were using a max dose of the pills before, maybe you can half those pills and have an even better response to what you were doing before. In your experience, what is the patient satisfaction like with the implant? That is a really excellent question, because I usually don't lead with this, but the penile implant from a patient satisfaction standpoint is actually the gold standard. There is no higher satisfaction rate than with the implant. You'll see different numbers, and the number that I usually quote people is an 85 to 90 or higher satisfaction rate. I tend to be a little bit more on the conservative side. I won't give an implant to just anyone who walks in the door. You really have to understand what you're getting into. There are other options, but again, for a well-selected person, there is nothing that can provide the on-demand, guaranteed, rigid erection like a penile implant can. So the satisfaction rates for those and the patient experience is, again, in the 90s. Let's see, there are specific questions here about dosing for pills. I really encourage appointments and discussing that individually with your provider. So this is a good question. And this is a question about sensation when the penile implant is placed. the implant does not affect the sensations of the penis at all. So the sensation of the penis comes from a bundle of nerves that actually fan out like a mesh along the top side of the penis. So not the bottom side where the urine passes, but the top side. And when the implant is placed, those cylinders are slipped in the side of those chambers or along the bottom of those chambers, nowhere near those nerves. And placing them internally, your sensation to your penis is completely unchanged with an implant in place. There is a question here about ejaculatory function. So that's a good question. If your ejaculatory function is normal before an implant, it will be normal after an implant. So ejaculation and orgasm is completely normal with an implant. The only thing that you have to realize is with a physiologic or a normal erection where it's filling with blood, it naturally goes down after orgasm or after climax. With a penile implant in place, that thing is not going down until you put it away. So if you have a malleable, that means folding it down. If you have an inflatable device, that just means using your pump in the way that it was designed to allow that fluid to go back into the reservoir. There's a question here about size. Size is a really common question with penile implants. Now, I said this earlier in the talk, the penile implant is custom fitted to you and your anatomy. And that's not just like this measurement when you look down. This is a measure 2 or 3 times internal measurement of each side of the penis, each of those 2 chambers, like distally, which means away from your body towards the tip of the penis, we measure on the inside, and then actually backwards, because the penis actually goes all the way back towards the pubic bone. And a lot of men, you can have up to half of your penile length back there. So we measure in both directions on both sides to get the biggest implant that will safely fit into your body. So when you have an implant, your penis is not getting shorter, it's not getting thinner or anything like that. There are different companies and different types of cylinders that say, oh, this one gets fatter, this one gets longer. The bottom line is we put in the biggest cylinders that we can, and we give you what you have at the time of the surgery. There's a question here about the data and efficacy of ultrasound. So there is something called shockwave therapy for erectile dysfunction. That is another thing that is still kind of in the investigational phase, but the difference with that is it is readily available. So you can find and pay cash for those therapies to be done, but the science to really prove how well they work or whether they work or whether they're better than this or better than that, they haven't been done yet. So there are trials at some centers that are investigating ultrasound therapy. What we do know is that these shock waves are very safe. They're used for a lot of different applications. So there is very little bad that can happen with this therapy. But again, these are not necessarily ready for prime time. They are available, but you really need to discuss this closely with your men's health specialist. So I think we have time for a couple more questions here. There's one question here about if you can obtain but not maintain an erection, what would you recommend? And actually that is a great question because that is a very common problem where you can get a partial or a complete erection, but it's not quite lasting as long as you want it to have a satisfying sexual experience. I really lean heavily on the ultrasounds in that case because that could be an issue of what we call venous leak. So you could have enough blood flow to the penis, but if those veins are not collapsing and holding that blood in place like they're supposed to, then that could be leaking back, and you could use as much of the trimix or injections as you want, and it's never going to work. And those are the patients who really do best with the penile implant. And the reason why I do that early is because I don't want men wasting their time with therapies. They're just not going to work for them. I think that is all the time we have for today. These are really excellent questions. If there are any other questions here that you did not have an opportunity to have answered, please reach out, schedule an appointment with us. I just want to put in a quick thank you on behalf of Coloplast and on behalf of the United Urology Group and Chesapeake Urology. It's been great chatting. Take care. Stay safe.